Hello, I'm Dr. Brawley Wong. My pronouns are she, her. I'm a board certified family physician and I love gender and reproductive health care. Today, let's talk about the potentially scary moment when a doctor says you might need to stop your estrogen. Estrogen, just like any other medication, has potential for risks and potential for side effects. In gender affirming care, it's important that we weigh the risks of these potential side effects with the benefits of treatment. Today, let's look at a case and discuss if stopping estrogen is a must, a maybe, or not necessary at all. As always, healthcare is very specific to the individual and varies case by case. So, if you're experiencing something like this situation, I encourage you to talk with your doctor who knows you and your situation best. Case 1 is Melody, who's a 32-year-old woman who was assigned male at birth. Melody has been on estrogen and spironolactone combination therapy for the past 10 years, and her dysphoria has significantly improved. However, she still has a lot of dysphoria and discomfort with her Adam's apple. This leads her to wear scarves and even turtlenecks in the middle of summer just to cover up. After doing some research on surgeries to reduce the size of the Adam's apple, she decides to speak with an ear, nose, and throat surgeon who is recommended by her endocrinologist. The ears, nose, and throat surgeon is very supportive of her decision and schedules her surgery for the next month. But they ask that she get medical clearance prior to the surgery from a primary care doctor. Melody has not seen a primary care doctor in a while, so she scrambles to find the first available appointment with Dr. Smith. Dr. Smith reviews her blood work and does a complete physical exam, all of which are normal. Dr. Smith is just about to sign off on the surgical paperwork when they note that Melody is taking estrogen. Dr. Smith shares with Melody that they do not regularly provide gender affirming care, but they do know that both estrogen and surgery increases one's risk for blood clots. For this reason, Dr. Smith recommends that Melody stop her estrogen 1 month prior to surgery to help reduce her risk of blood clots. Melody is terrified at the thought of potential dysphoria she may experience if she stops her estrogen. Pause. So, what should Melody do next? For the medical community, do you agree with Dr. Smith? If you, like Melody, have ever been scared by a medical recommendation, I encourage you to please advocate for yourself by sharing your feelings and asking questions. For example, Melody could say something like, I'm really scared of stopping my estrogen. Are there any other options to safely prepare for surgery? Or she could say something like, the idea of stopping estrogen makes me uncomfortable. Could you give me more information about the risks and benefits of stopping versus continuing my estrogen? A good healthcare provider will be more than happy to answer these questions. Furthermore, a trustworthy healthcare provider will be comfortable admitting if they don't know the answer and will offer to look it up for you or refer you to a specialist. For the medical community, did you agree with Dr. Smith? If you disagreed with Dr. Smith and said that it's not necessary to hold estrogen prior to surgery, you would be correct. For most cases of elective, non-emergent surgery, there is no need to hold estrogen or other hormonal therapies like testosterone prior to surgery. An endocrinologist I once worked with explained it best by saying, would you give a cisgender woman something to block her estrogen prior to surgery? No, of course not. One of the goals of feminizing therapy is to reach estrogen levels that are similar to that of a cisgender woman. Therefore, if you would not block a cisgender woman's estrogen prior to surgery, you should not withhold a trans woman's estrogen prior to surgery. Let's wrap up the case. Melody courageously shares her feelings and asks Dr. Smith about other options. Dr. Smith admits that they're unsure of alternative options, but is willing to look it up for her. This prompts Melody to share that maybe her endocrinologist could help. Dr. Smith reaches out to the endocrinologist, who clarifies that it is not necessary in most cases, including Melody's, to hold hormonal affirmation therapy prior to the operating room. Dr. Smith thanks the endocrinologist for teaching and finishes the surgical paperwork. Melody proceeds to take her estrogen as regularly scheduled and has a successful procedure the next month. So, what questions do you still have? What scenarios should I go through next? Leave your questions and wisdom in the comments below. And if you like today's content, please consider liking and subscribing so that we can reach a wider audience with this education. Thank you. See you later. Zola.